All right. With that, my disclosures really shouldn't be a problem. So I'm going to take a little different approach than I normally do here, and I changed around my slides, and I just want everyone to stop, relax, and look at this picture and say, okay, what are we doing? And if you saw these MRIs, which one do you want to be? And so this actually changed my life about 15 years ago. The thing you see here is the guy with the obvious, the spinal cord that you would be like, oh my God, that's horrible, actually is the person who's walking around with some spasticity and some sensory changes. The person who is the complete injury, who looks like they have an intact spinal cord, is actually the Asia A. And why is that important? And I think this is somewhat of an important thing. It's what neurons you save. John, you were showing the image of the patient with the neurons in the recovery. It's interesting in the sense that why in the chronic model can you have so little nerves that regenerate and resprout as opposed to an acute where distal cord actually looks pretty normal. And our job, or at least I look at my job, is to try to save any neuron I can, because when I started a residency, spinal cord injury was you got what you got at 6 months, you're not getting better. And I want you all to step back and look at all the research and data that's come. The stem cell trials have shown changed in chronic spinal cord injured patients. The Susie Harkema's work with electrical stimulation has drastically changed people that we never thought would get better. So with that said, we're going to go on and I have 5 different things. When you give a talk, they all say, yeah, your audience, if they can get 3 things, you should be happy. But you guys are a bright group, and so I'm going to go for 5 things. Although if you just read that paper that neurosurgeons probably aren't smarter than the general population, we might be in trouble. So with that said is, does earlier decompression of spinal cord improve neurologic recovery? 2 is all spinal cord injuries the same? And I think you guys heard a couple people say that's probably not true. What we never talk about is the process and how well are we doing things. Are we efficient at doing early surgery if we all believe early surgery is good? And should every patient be done emergently? Guidelines are guidelines, and they should give you guardrails what to do, but you have to stop and look at the individual and how to treat with them. And lastly, for Bijan, are we as good as we really think we are? Did we really do that decompression? Next year, we're going to have Bijan's talk after mine. So, really,
Jim, that's why Dr. Okonkwo delayed his lecture to follow yours. Strategic move. Your Pittsburgh buddy kind of outflanked you there, outmaneuvered you.
No one said Dave wasn't a very bright guy. So with that said, is early surgery animals, no brainer. Every animal study has shown that the earlier you operate on, the better outcome you can get. The problem is there's multiple flaws operating in a test tube. So we have to go back and we have to look at what's the human data say. It's funny, when I started 20 years ago, we used to be the debate of, well, should you do early surgery? And all of the data, length of stay, complications, supports doing early surgery. And we've sort of totally forgotten all that data which supports early surgery. Now the question is, all comes down to neurologic recovery. And I think if you go back and you trace all these papers, you get the gleaming of, yeah, surgery does. And John, I actually totally agree with you about Staskis, and you and I can go offline about it. And every study has some flaws. This study, I think the flaw with it is everyone's message that they get from it isn't what the paper says. And so I'm going to go back to what you said. And again, really what it was early versus earlier, 14 hours versus 48 hours. Now you got to remember, we were doing this in about 72 hours. And this included people that got traction as well as open surgery. And in this slide, which you showed, sort of sums up everything. And what does it say? It says that 2-point or 3-point improvement is the best outcome if you do patients less than 24 hours. Now, why is that important? And this goes back to the central cord conversation we were having. You're not going to make an Asia D and Asia F. But the 2 groups that are probably going to benefit the most are your Asia A's and your Asia B's. Why is that? Because an Asia A can go to an Asia C or a D, or an Asia B can go to a C or a D, and potentially an E. But I will argue with everyone that I'm not really, when I see Asia E's in a population, I get very nervous because in my experience, many spinal cord injuries, excuse me, most, if not all spinal cord injuries have some residual problem. It's exceptionally rare that they get 100 points in normal sensation on their exam. So with that said, well, how bright are we? And unfortunately, we're not that bright, because here's a nice look at the traumatic spinal cord injury. And what do we all think? It says that, and if you look at this, and I'll just look at the first 3 bars. Basically, in Asia A, we're least likely to take that person to the operating room. Matter of fact, well, most likely, more people are willing to take a central cord injury patient emergently to the operating room than in Asia A. And what I'll argue is that we should probably be thinking about things the other way around. Asia A's and Asia B's we should take to. And it's not just me saying this. If we go through, and here's a meta-analysis where we look at it, completes versus incompletes, the complete patients had a much better improvement in neurologic recovery versus the incomplete patients. Matter of fact, the incomplete patients didn't make that much of a difference. Now, why is that? Probably the incomplete patients have less of a neurologic injury, less of a mechanism injury, and most importantly, as John pointed out on his slide, probably the most ability to recover naturally without us even intervening. Michael mentioned this paper, which is actually a very good paper. And if you look at it, patients were about the same. What was the conclusion? Well, the earlier surgery patients in 1,000 patients. Now, these were a combination of multiple databases. And John, it sort of diluted that effect you talked about earlier about the A's and B's being different. You got a 4-point improvement if the patients got early surgery. And you might argue, well, 4 points isn't that much, but I will tell you, if you can't use your hands, which is what most of these patients have, I would take those 4 points very readily. So the next question, and this goes back to a different philosophy, and I've been at Jefferson, and our general philosophy is get the patient in the operating room as early as you can. And every patient's an individual. My partner just did a patient 3 days ago. He called me up and he's like, the patient's hypotensive, and I brought him to the operating room, and the anesthesia people didn't want to put him to sleep. Now, to me, that makes complete and rational sense, because the goal, as Bijan said, is to perfuse the spinal cord. If you're going to flip the patient and they're going to crash, you're probably not doing the patient's neurologically a lot of benefit. So another study, again, what did it show? Less than 8 hours. Again, a meta-analysis, smaller groups of patients. But again, the complete patients did much better in terms of recovery than incomplete patients. And you can see the diamonds at the bottom that you are most likely to have a potential recovery with completes versus incompletes. Here's another patient's paper, but this is actually, to me, a little bit of a game changer. Vafa, who is from Tehran, extremely bright gentleman who's done tons of work in spinal cord injury. He actually wrote a paper about 20 years ago that you probably shouldn't rush thoracic ASIA spinal cord because it didn't affect your outcome. And what he's seeing here is somewhat of a familiar curve when you look at it. Yeah, potentially this group could be doing better. But again, this is one paper in a different environment than I think a lot of us are used to. So the first thing is, I think there's a preponderance of data that doing surgery early for spinal cord injury is probably indicated. Now, how about this question? And this was brought up by several of the other presenters, but I'll make it even more obvious. Are all spinal cord injuries the same? We tend to look at studies, analyze studies, and say, oh yeah, spinal cord injury is the same. The problem is, as you can see from this example, you got the patient with the transection spinal cord versus the patient with the central cord injury. They're not all the same. And I think we have to stop getting into the mechanism of treating all patients' pain. I really like the conversation by Wyatt about outcomes and scales. And I think he's right on where we say we may need to stop the way we're thinking about things and build our outcome studies the opposite way we do, meaning that research people probably need different information than nurses versus surgeons versus rehab people. We have adopted a rehab study and metric, which was designed to communicate to rehab centers from one center to the other, the patient's condition when they're transported. So I think there's definitely more work we can do with our measuring of spinal cord injuries, particularly, as most of you probably know, central cord injuries. Jens, do you have a question? Nope. So this is another paper. When I did it, I made it really easy for you guys, where I took all the central cord injury, and you saw sort of a somewhat effect with the regular traumas. The central cord population, green is good, yellow is we're not sure, and the red is bad. This group, you didn't get the same effect from early surgery. And so it goes back and it says, we need to step back and look at spinal cord injuries different. And again, going back to the guidelines from spinal cord injuries, it sort of confirms the same things. The third thing we don't, and actually John Harrop mentioned this in his slide, if you talked about it. And by the way, just for the record, John, Bijan copied my paper, which I wrote even before him, about the 600% increase in geriatric spinal cord injuries at our center. But what we saw was this, is the mechanism of injury is completely different. So you're talking about a fall injury with a stable spine versus when I know Jens or the other people in the audience, I don't see kids getting car accidents much anymore. And I definitely don't see diving injuries. I can't remember the last time I saw a diving injury. So the population is completely changed as we look at demographics, and John showing Bijan's work is true. The one thing I do want to say is, you have to do some self-reflection. And Jens, you mentioned Registry. Well, there is a registry that's been around for over 20 years called the North American Clinical Trials Network. It was Bob Grossman, as most of you probably know, passed away. God bless his soul. Extremely bright and dedicated gentleman. The interesting thing is we had a DOD grant for numerous years, but the problem is the government and many agencies aren't interested in funding registries anymore. And so I think the comments about using passive collections through Epic and other ways, probably how we're going to have to get a lot of our information about spinal cord injuries down the road. But with that said, is if you look at this, Enactin, you probably would say is probably 10 of the more aggressive surgical sites in the country. Only about less than half of the patients had surgery within 24 hours as we reflect back. Now, some of that has to do with the changing of times, but I think we all have to go back and try a little harder or see how we can do things better. And so with that thought, this is actually 2010. I went back to the state of Pennsylvania has a very interesting registry system. And with that, every trauma patient gets put in a registry. And what you find out is this, is that we, meaning that emergency room physicians, are much more likely to let a trauma patient sit in the emergency room for 24 hours. The mean was the longest for spinal cord injured patients versus anyone else in the country. So we need to communicate to our colleagues that, hey, we need to get spinal cord injured patients into the tertiary centers ASAP for two reasons. One is to get them into decompressed, but also if you look at the pharmacologic effect of most drugs, there's probably an 8-hour window is what we're going to probably want versus a 24-hour window. And as bad as we have it, and I'm not to say this, I'm just speaking out for the group, is we're lucky that we are where we are and we have very established systems. If you look at the other places in the world, patients' delay is extremely long and multiple different things. As a matter of fact, as bad as your OR is, Jens, guess what? It's not as bad as other places because they close the OR down due to financial reasons or other issues. So we are lucky. Third thing is every hospital is different. I came from the largest, we used to put everyone in traction. Matter of fact, if you came into my hospital with carpal tunnel syndrome, sometimes we'd put you in traction. But we put everyone in highway traction. And what we found out is as the system changed, and I personally believe traction is a very, it's a hard thing to do correctly. It's a skill and it takes a lot of practice. And we would traditionally, put 150, 200 pounds on people's heads. But the problem with that is if you don't get them reduced, you end up delaying their care. This paper STAR was actually from Jefferson, 93% reduction, but it took over 8 hours for the patients to get reduced. And so we've changed our process to taking the patient directly to the operating room. So at our hospital, you come in, you go to the CAT scan, you get a sagittal and axial T2, and then you go right to the OR. And it's probably worked out for the bus. So some people have different ways to do it, and I think that's great. But you should probably just reflect back and say, what is the fastest way we can get the patients to the emergency room and do it in a controlled manner? And that goes to the question of, should everyone be done emergently? And if you start looking at our surgical subspecialties out there, people don't do well with emergent surgery. So this is a paper with the colorectal people, and they showed that mortality rate 10% higher if you did it in the middle of the night. Now, yes, it could be a sicker patient or whatever, but definitely there's a correlation in the literature that if you do things, if you do things at night or as an emergency, you probably don't control all the variables as well. And so you must be careful. The most vulnerable group, and this goes back to who's the most vulnerable group in our populations now, it's actually the elderly, central cord injuries, as we talked about, that are Asia Ds, which probably won't benefit the most from early surgery. Those are the ones that do the worst with surgery in the middle of the night or early. And they also have the highest number of post-op complications. I guess my last question is, this is my tribute to Bijan because I always make fun of him. Bijan, this is actually a great paper. And I do think we should recognize it for several reasons. One is, Bijan's the only place in the world that gets an MRI every 6 hours on his patients in the post-op period. Matter of fact, they actually built the ICU around the MRI machine to make it easier for him. He's been fantastic, and what he does is he serially MRIs his patients, and that's why he has such a great literature. But it shows a couple things. One is an ACF doesn't decompress the spinal cord that well. It'll decompress the focal compression, but not the entire spinal cord. And that makes sense, right? Because if you look at the body, about a third or a fourth of the canal is the disc herniation. So if you want to decompress a cord, it's probably more beneficial to do a laminectomy than a ACDF. The thing I somewhat disagree with him about is, how do we do it? And I think that's where you need to jack up their blood pressure. I think there probably is a role for CSF diversion. And I think there probably is a role for pharmacologics and other tools, any tool we can have to push the spinal cord to the best recovery possible. And with that, thank you, Jens. Oh, I got one last slide.
Good job. Really well phrased. So 2 quick questions before we move on. One is, again, from Bijan's review, it seems that we should actually do more and more dramatic surgery to avoid this proximal or rostral cord swelling. So the case for prone position durotomies and expansion duroplasties has been made. Is that something that's an emerging reality where we do an emergent reduction, an anterior fixation, and then if the patient is stable, flip them over? How do we kind of adjudicate who needs that more invasive, very dramatic surgery and who doesn't?
So I think Bijan's example was an extreme example. If you look at that was a younger person with a flexion distraction injury, and their cord had malignant edema. In the old days, we used to call that an ascension. I wrote a series up of them, about 8 to 10 of them. And I got to tell you, I haven't seen one as an attending in the last 20 years. And I think that's because we hypertense the patients much better than we did in the old age. Matter of fact, someone mentioned Frankel. Frankel back in 1969 in paraplegia wrote the first case report from it. Bijan, write that down. And he documented how its thoracic patient slowly went up their spinal cord. So I think, they get in this cycle where they reperfuse it. Most patients, I don't think need that, but I do think he is correct. We probably don't decompress him as well as we can.
So since you talked about a bilateral facet dislocation, then we'll need to move on, but I hope you can stay online for your favorite cross-state counterpart, Dr. Okonkwo. So let's say you have a bilateral facet dislocation, significant neurologic injury, best guess, C6-7 musculoskeletal injury, C6 neurologic injury. Your paradigm now would be get an MRI or not, and then take him to the OR, yes or not?
So our paradigm now is you hit the door. Most of these trauma patients get a CAT scan through their whole body. as soon as they hit the door. And we have one actually in our emergency room. Then they go right to the, matter of fact, most of them have it done at the outside hospital. Then they go to MRI. We have the OR called, and then we usually bring them up right up from the OR, assuming that the trauma guys don't have any other major concern or issue.
Okay. And then why does this ascension, I know you don't want to use that word anymore, happen? Is that maybe too much hypertension and then reperfusion trauma, or are these just specific injury mechanisms or age groups?
I think it's actually funny. When we looked at it, it was young males with the hyperflexion injury. And I think it's because their mechanism injury is so bad. Two, it's because, and I'm embarrassed to say this, but I will say this. When I was a resident, we used to have a philosophy of, well, the guy's blood pressure is 40, but he's perfusing and his kidney's making great urine. Why would you jack their blood pressure up? And I think that's one of the biggest things we've learned in the last several decades is maintain their blood pressure and hyperdynamic their blood pressure to try to perfuse the spinal cord. And I think that's, we're all talking, my vascular colleagues would be so happy. It all comes down to blood flow. I mean, why do you decompress them? The only reason you decompress them is to improve perfusion of the spinal cord. And how do you do that? And I think we're trying to figure out new ways to do that.
Was Bijan's first slide. Continue down. What's the ideal vasopressor to use then? I saw some attempts at systematic reviews, and I guess that the literature is still not clear about that. Is phenylephrine the best, or dopamine, or what's the current state of knowledge?
We use phenylephrine. I know Michael's group uses dopamine. If you think about it physiologically, it's an alpha. They get a sympathectomies, and so they lose their ganglions, and so they lose their their epinephrine control. And so to me, that makes the most sense, because really what you want to do is you want to tank them up with fluid, which tends to happen fairly well, and then B, you want to constrict them peripherally. And so some people will say having the heart be more dynamic is a good thing, but I'm like, it makes more physiologic sense to try to bring them back to normal to me.
Andrew has a question.
Yeah, just a quick question, Jim. It's kind of a philosophical one. We all know time is spine, but when you are doing these sort of in hospitals in the middle of nowhere, trying to get people reduced and so forth and so on, should we really be referring all these patients into tertiary centers, or should we get everybody trained up to do emergent spinal cord injury surgery?
And I think that's a great question, Andrew. And I think I'm going to throw it a different way. I have to either say I think what technically everyone can do these, right? I mean, the number of spine surgeons out there with the skill set's unbelievable. So if you're going to say, I'm going to do it, my hospital has the things to do it, then do it. I even tell the people around me, I'm fine with you operating on them and sending to us post-operatively, because I'll take care of them post-operatively if that can get it done faster. And our trauma team has been fully receptive of that, because as you guys probably notice, every now and then you'll get a phone call and someone will be like, well, we're on lockdown, divert. And I'm like, just get it done. I'll take care of them post-operatively. I mean, I have zero problem with that, because I do believe early surgery is the important thing. I think post-op care for the patient is important, but if you have the skill set and the means, I would say do it at your place, but do it in a timely manner. I wouldn't say, okay, I'm going to sit on this guy for 6 days and then, it's Thursday, so I'll do him next Tuesday. I mean, I think that's probably not what we want.